Okay, hello. We're going to be doing, this is the first of what will be probably two parts involving the skeleton. Now, when you look at the skeletal system consists of the axial skeleton and the appendicular skeleton. We're going to first start off with the axial skeleton. This is along the longitudinal axis of the body, which includes the bones of the skull, the hyoid, the vertebral column, the ribs, and the sternum. Bones have certain functions. We've talked about some of the individual bones and how they help to keep the body functioning, but now what we have to do is look at the structural importance of it. So, when we talk about the functions of the skeleton, they support and protect the brain, spinal cord, heart, lungs, kidneys. Along with muscles, they adjust positions of the head, neck, and trunk. They help you to perform breathing movements. Basically, as the thoracic cavity is enhanced with muscles and the ribs, you're basically allowing yourself to have take a breath in, and then as this all relaxes, a breath out. They stabilize and support the appendicular skeleton that supports the limbs. Now, the joints of the axial skeleton, when you compare them to the appendicular skeleton, have more limited movement, but they are very, very strong and they are heavily reinforced by ligaments. The appendicular, you have the bones of the upper and lower limbs. They include bones of limbs and bones of the pectoral and pelvic girdle. They basically are the attachment sites of the limbs to the axial skeleton. So their functions include movement of limbs, production of heat and release of heat from body core. Also, you will notice the functions of the girdles. In the girdles, you have both a pelvic girdle and a pectoral girdle. Pectoral is the support of the upper limbs. It is not as strong of an attachment to the axial skeleton. The pelvic, which actually has the coaxial bones attaching directly to the scapulum, are much, much more stronger in their attachment. We're going to focus on the later on in the chapter on bone markings of the girdle and limb bones. Here, we talk about the skeleton. And in the skeleton, you see the axial skeleton structures that are going to be described first. Those are all in yellow. So that'll include skull, it includes hyoid, it includes ribs, it includes the sternum, and of course the vertebrae. And the vertebrae do include the sacrum, which really is fused vertebrae, and the COCCYX, which is a fused vertebrae. The appendicular skeleton is the girdles that you see that make up the upper limbs and the lower limbs. And as you can see here in this description, one of the things you want to be aware of right off the bat is that the skull is not a solid bone, but made of a bunch of other bones that fuse together. And that's one thing that I encourage you to take the time and review and identify all the different bones that make up the skull. In the appendicular skeleton, you can see that there is an attachment from the clavicle to the sternum here, but that's the only attachment for the upper limbs. The lower limbs, that's where you have the hip bone, otherwise known as the os coxae. That's part of the pelvic girdle here, which is attached directly to the sacrum. And that is where you're going to get the supportive girdles, the pelvic girdle and the pectoral one. We're going to get in more of this as we move on. So let's take a look at the skull first. The skull has cranial and facial bones, which are fused by sutures. Remember, this is where you have the bones fused together. They would be considered sutural joints. Okay, let's look at the facial bones. The facial include the maxillae, the palatine, nasal, inferior nasal conchae, zygomatic, lacrimal, vomer, and mandible. Now, the mandible, of course, is the lower jaw. The maxillae would be what you consider part of the upper jaw. These also play a role in supporting entrances to respiratory and the digestive tract, as well as the attachment areas for the muscles for facial expressions and manipulation of food. When we take a look at the bones that make up the cranium, their function is to protect the brain. So this is including the occipital, parietal, frontal, temporal. The sphenoid and ethmoid are not as easily seen, and they're also not purely sort of the flat or curved plates that you've seen, the flattened sheep bone that you've seen before, where it's compact on the outside, compact on the inside, diploe in the center. So you have to keep this in mind. But they basically all play a role in enclosing the cranial cavity, keeping it fluid filled and stabilized by the membranes, protecting the brain. That's the key point. Okay. Outer surfaces provide attachment sites for muscles that move eyes, jaws, and head. We're going to talk a little bit later about the associated bones to the skull. The hyoid is not attached to anything, and it helps as a support for the muscles of the tongue. The auditory ossicles are actually located inside of the temporal bone. We'll deal with this a little bit more later, but basically, to give you a short one sentence, they basically play a role in hearing conduction. And here you see the differentiation when you look at a skull between the facial bones and the cranial bones. You can see where the nasal, zygomatic, maxillary, mandible, vomer, and the lacrimal bone. And then, if you look at the cranial bones, the frontal, parietal, temporal, and occipital. Notice how they're all held together by these sutures. And then it's a little bit more difficult, but you can see the sphenoid peeking out as well as the ethmoid. When we talk about sutures, we're talking about basically joints where the bones come together, but there is no movement, okay? So the sutures include the coronal, which attaches frontal to the parietal bones, both sides of the parietal. The squamous, which forms boundary of the temporal and parietal bones on each side. The sagittal, which extends from the lambdoid to the coronal sutures between the parietal bones. The lambdoid arches across the posterior surface of the skull, connects the occipital bone to both of the parietal bones, and it's usually the common site where you're going to get sutural bones. Those are what they call Wormian bones. Basically, what we're looking at is bones that, they're sort of like little islands situated between two of the sides of the sutures, and there's differences between you and I and all of that, so they're not really counted. In the calvaria, the skull cap, that forms the roof of the skull, and it's composed of the occipital, parietal, and frontal bones. Excuse me. And you can see here is the lambdoid suture. The sagittal suture holds together the parietal. You'll also see some Wormian bones in there. And then, of course, you've got the squamous suture here on the lateral view between the temporal and parietal. And then, of course, you've got the coronal suture here between the frontal and the parietal. When we talk about facial bones, you want to keep in mind that some of them are paired, others are single. They provide support and forms of selective structures that we would keep or be familiar with in the sense of the face, mouth, nasal cavity. Paired bones. When we talk about the paired bones, we're talking about the nasal. This is the superior portion of the bridge of the nose. The lacrimal, which is part of the medial wall of the orbits. The palatine, which is the posterior part of the hard palate and floor of the orbit. Keep in mind, when I say orbit, remember, this is the area where the eye is going to be located. The zygomatic is going to present itself as the rim and lateral wall of the orbit. I apologize for the typo, as well as the prominent cheekbones. And then the maxillae, which forms the site where you're going to have the upper teeth. And that forms the inferior orbital rim, the lateral margins of the external nares, the upper jaw, and most of the hard palate. This is what we talk about when we talk about paired bones, the facial bones. We also have an inferior nasal conchae. Now, the conchae are these little, if you almost think of them as curved shelves inside the nasal cavity. They are the site that basically where the olfactory epithelium is located. That's when you sniff. You're creating turbulence in the air to enhance the odorants, the molecules that will tell you whether it's a rose or a geranium or, rotten, spoiled milk or anything else. You got to create that turbulence to have the odorants pass over the olfactory receptors to tell you what it is. But the other thing that we have these conchae for is so as air passes over them, the air is warmed and it is humidified. Now, there are a few single bones in the facial bones. The vomer, which is the inferior portion of the bony nasal septum, and the mandible, which is the lower jaw. And you can see this here. Here's the inferior nasal conchae, 1, 2. You see in here some of these other structures, which are actually part of the ethmoid. And then, of course, here's the orbit of the eye, which you have contributing the frontal, the zygomatic, the sphenoid. Of course, you're going to have the ethmoid, and you're going to have the palatine bone contributing a little bit, as well as the maxillae. Now, keep in mind that there are some bone markings here, here, and here, and here, and here, and here. We're going to get into those in a few minutes. When we talk about the cranial bones, these contribute to the interior and some of the external features. Okay, cranial bones, think about it, primary job, protect the brain. You have the parietal bones, which are paired. They form the superior and lateral surfaces of the cranium. You have the occipital, which is sort of the back of the head, right there. Contributes to the posterior as well as to the lateral inferior surfaces of the cranium. The temporal is also paired. Okay, so that's the sides of your head. And that forms part of the lateral wall of the cranium. When we say it articulates, it forms the joint with the facial bone. So they meet, but they're held together by sutures, and forms articulation with the mandible. Now, in this case, you actually have a movable joint. You probably have heard of temporal mandibular joint, TMJ. Also, the temporal surrounds and protects the sense organs of the internal ear. Inside of the temporal bone area, that's where you're going to find the auditory ossicles and the rest of the inner ear structure. Also, the temporal are the attachment site for muscles that close the jaws and move the head. The mastoid process is attachment site for muscles that rotate and extend the head. You can feel those behind your ears, sort of these bumpy structures. Okay, then we have a styloid process. If you look and take the skull and hold it upside down, you're going to see these pointy little structures. These are attached to ligaments that support the hyoid bone and to tendons of several muscles. The external occipital protuberance, this is a crest that extends inferior from it. This is the attachment site for what is called the nuchal ligament that helps stabilize the vertical vertebrae. And you can see this, if you're looking down here, you can see the external occipital protuberance here. You can see the external occipital crest right here. There's those styloid processes, those little points here. Okay, you've got basically occipital bone, parietal bone, sagittal suture, lambdoid suture, etc. And then, of course, you've got the mandible right down there. Lateral and medial aspects of bone markings. I want you to be aware of some of these things. They're going to be extremely important. As we move forward, bone markings are going to be important in not merely just identification of the bones, but they are going to be important sites where you're going to see connections for tendons, ligaments, some cases direct attachments by muscle, openings for blood vessels, nerves, etc. When we talk about the forehead, there's an attachment for the facial muscles. They form anterior and superior portions of the cranium, eyebrows, the scalp. The alveolar process of the maxilla has projecting ridge. These are the sockets for the upper teeth. The alveolar part of the mandible surrounds and supports the lower teeth. We're going to get into this later on in chapter in joints, I believe it is. I think it's chapter 8. We talk about gymphosis, which is basically non-movable sort of joint, but it's held in its place, the teeth that is, by a sort of very fibrous attachment. Okay, and we'll get into that later on next week. The mental protuberance, the chin, is the attachment site for facial muscles, and then you have the mandibular angle, which is posterior and inferior corners of the lower jaw. When we talk about the zygomatic arch, this is formed by the temporal process and by the zygomatic process. this is an interesting way to put it. You ready? The temporal process of the zygomatic bone and the zygomatic process of the temporal bone, both of those processes become what we call sort of the cheekbone, the extension, that arch. Okay? Overall, they call it the zygomatic arch, but it's composed of two processes. And so what you have is the temporal process is on the zygomatic bone, the zygomatic process is on the temporal bone. We have also the external acoustic meatus, and this ends at the tympanic membrane. It's sort of the opening in the skull for the hearing. The squamous part of the temporal bone is an irregular convex surface of borders. It basically borders the squamous suture. Superior and inferior temporal lines. What about those? These are curved ridges for attachment site for the temporalis muscle. Basically, this is on the side, and it closes the mouth. You can see this over here. Here, as I said before, you have the temporal process. Here you have the zygomatic process. This is the temporal process for the zygomatic bone. This is the zygomatic process for the temporal bone. Here you have the mandibular angle. Here you have the mental protuberance, the alveolar part of the mandible, the alveolar part of the maxilla, where the teeth are located, okay? And of course, the external acoustic meatus. This is basically where you would have the auditory canal going into. You want to be aware of a couple of other things. The locations of the sphenoid sinus and the frontal sinuses. These are hollow spaces in bone. They vary in space and in time of appearance. All sinuses tend to lighten the weight of the bone, of the skull as a whole, but also are involved with phonation. If I was to block my nose like this, class, you would hear a different voice, okay? Because what I've done is block off the phonation, the making of sounds, the voice, as it goes through and is basically resonating through my nasal cavity, and including going through some of the sinuses. We have also a hypoglossal canal. Hypoglossal nerves pass through this canal. The internal acoustic meatus. Now, what you have is a passageway for blood vessels and facial and vesticochlear nerves. Basically, this is sort of, we go in on the external side, we come out the internal side, and basically all in that little area is the processing of sound to vibrations to neural input. We'll get into that toward the end of the course, and it gets fascinating. Then we have the petrous part. Petrous, think of like stone, okay? And this is enclosing structures of the internal ear, including housing the auditory ossicles. And you see this over here. Here's the internal acoustic meatus. You can see the hypoglossal canal, styloid process again, etc. I want you to try to have some appreciation for some of this now, because it's going to be extremely important later on. The sphenoidal sinus, and you can see as we go up through here, I've mentioned this before, this is where you're going to have the sella turica, the hypophyseal fossa. That's where the pituitary is going to be. Mandibular fossa, the articulation site with the mandible. Occipital condyles. These are all the foramina that you see when you turn the head upside down, you look down into it. Okay, what you're going to do here is you're going to look at upside down the skull. You will see occipital condyles. These are articulation sites, joint sites for the skull and for the first vertebral, the cervical vertebrae. If you remember that, the first cervical vertebrae is called the atlas, okay, for the vertebrae. The inferior and superior nuchal lines, these are ridges that intersect with the occipital crest. Muscle and ligament site for stabilization of occipital condyle articulations, as well as they balance the weight of the head over the cervical vertebrae. Think about this. You don't have to do much to keep that head up straight. Now, when we talk about the term foramina or foramen, you're going to be talking about openings. So, in the sphenoid bone, You have the foramina lacerum, that's between the sphenoid and temporary bone. It supplies small blood vessels into the brain. The foramen ovule is a passageway for nerves innervating teeth and jaw. When we talk about the temporal bone, we have the carotid canal. This is a passageway for the internal carotid artery, a major artery to the brain. This is where blood flow will exit the foramen lacerum. So what I'm saying to you is this. You have blood going into the brain by the carotid canal and leaving by the foramen lacerum. Stylomastoid foramen. This is where you have a facial nerve that passes through to control facial muscles. On the occipital bone, you have several other of these very important foramina. The jugular foramen, which are basically have the internal jugular vein passing through, carrying venous blood from the brain. Okay. The foramen magnum connects the cranial cavity to the vertebral canal. It basically surrounds the connection between the brain and the spinal cord. You can see this here, foramen magnum, jugular foramen, styloid foramen, carotid canal. You can see the foramen ovule, okay, the foramen lacerum, all right. Now, for some of you, this gets to be overwhelming. Take it slow, but start to ask yourself, what are these things doing? Okay, if you see here the palatine bone and the upper part of the maxilla, that's the upper hard palate. Later on, you have that soft palate, which is more cartilage. When we look at the ethmoid bone, we have foramina in the sense of the olfactory foramina. These are a series of small holes in what is referred to as the cribriform plate. This is a passage for olfactory nerves that will eventually travel into the nasal cavity. The sphenoid, this is the optic canals, the passageway for optic nerves. They connect eyes to brain. Foramen rotundum, that's a passageway for the passage of the trigeminal nerve. That's one of the important cranial nerves that we're going to be talking about later on down the road when we talk about the brain. The foramen ovule and the foramen lacerum I'm going to skip because we've already dealt with it. The foramen spinosum is a passageway of blood vessels to membranes that surround the central nervous system, that is the brain. I've already dealt with the carotid canal and the internal acoustic meatus, so I'm going to just kind of skip over that. In the occipital, we've already talked about the jugular foramen and the foramen magnum. We do need to be mindful of the hypoglossal canal, which is a passageway for the hypoglossal nerve. That also is one of the cranial nerves. Then we have the internal occipital crest. This is a ridge in the cranium. It is very, very important for anchoring blood vessels and membranes that stabilize the position of the brain. And you can see that here. So we've been looking now, in this case, inward. We can see the internal occipital crest. We can see the crista galli, which also anchors membranes that hold on to the brain and won't allow it moving around. The cribriform plate is right here. We have the sella turica there, which is where the pituitary would be anchored into. And then we talk about the foramen rotunda, the optic canal, which is right there. We've already talked about the foramen ovule, the foramen lacetum, the foramen spinosum is here. And I'm going to ignore the telephone. Now, some of the foramen and processes have already been reviewed. And that's where I'm going to be putting 2 asterisks on the slide. Okay? The sphenoid forms part of the floor of the cranium. You have also the optic canals, which I mentioned. Now, there's going to be several other important structures. One of them is in the sphenoid, you have the lesser wings, which extends toward the sella turica. You have also the greater wings, which forms part of the cranial floor. That contributes to the posterior part of the orbit. Okay? These are unique structures. If you actually look, and I believe in the next slide we'll show you this, the sphenoid is this very bizarre looking, almost butterfly-like appearance, and that's why they gave it the term wings. The hypophyseal fossa is a depression of the sella turica. It's a site for the pituitary gland. And I mentioned before the sella turica is this bony, it's saddle-like. It protects the pituitary gland. The sphenoid spine is posterior lateral corner of each of the greater wings. We've already talked about the foramen spinosum and the ovule, and also the foramen rotundum. We also have the superior orbital fissure. This is a site where you're going to have blood vessels that supply blood to the membranes of the cranial cavity. We have the sphenoidal sinuses, which are inferior to the sella turica. The body, which is kind of, we've been focusing all on this sphenoid, and you'll see this as kind of a very strange, irregularly shaped structure. But it has a central axis, and there's also a pterygoid process. It's a vertical projection that forms pairs of pterygoid plates, which are attachment sites for muscles that move the mandible and the soft palate. The ethmoid forms part of the floor of the anterior cranium, roof of the nasal cavity, and parts of the nasal septum and medial orbital wall. Here is the sphenoid. I mentioned to you before, here are the lesser wings. Here is the greater wings. Here are basically the hypophyseal fossa. Here is also some of the other structures, the foramen rotundum, ovule, spinosum. Okay, so these are all very important for the sphenoid. Excuse me. Here is another view of the sphenoid. This is the anterior surface. So you have the orbital surface of the greater wing, great wing, less wing. Think of it as thickness. Sphenoidal sinuses, the body of this, sort of the centralized area. The pterygoid plates, the lateral plate, the medial plate. Moving onward, we're going to basically, again, mark off some of those that we've mentioned with the asterisks. When we look at the crista galli, this is a bony ridge where the falx cerebri, which I mentioned before, it's that membrane that stabilizes the brain, attaches. We've talked about the cribriform plate. The ethmoidal labra consists of the ethmoidal cells. They're air-filled sinuses, cavities. The superior nasal conchae, these are projections into the nasal cavity. This is covered with olfactory epithelium. Now, here's the point. When you look at the olfactory epithelium, the superior and middle nasal conchae are really part of the ethmoidal bone. It is the inferior, the lowest one, that is a separate bone of itself. The perpendicular plate, which forms part of the nasal septum, is also part of the ethmoid. There are other parts, that's the vomer bone and the nasal cartilage. And you can see this here. Here's the perpendicular plate, as you can see. Here's where the crista galli sticks up. And then you have the superior and the middle nasal conchae. Okay? Now, let's talk about the palatine for a minute. This forms posterior part of the hard palate, contributes to the floor of each orbit of the eye. In other words, the orbit of the skull there, okay? That's where the eye is going to be located. You have the perpendicular plate of the palatine that extends from the horizontal plate to the orbital process. The horizontal plate forms the posterior part of the hard palate. So think about it as horizontal versus the other plate that we were talking about a minute ago. The orbital process forms part of the floor of the orbit, contains a small sinus that opens up to the sphenoidal sinus. This is the tricky part, folks. Here's the horizontal plate. Here's the nasal crest. You can barely see it here from the front of the skull. Here's also a perpendicular plate here and an orbital process here. So it contributes to the part of the orbit of the eye as well as the nasal area. Now, I've mentioned this before, the orbital complex, the nasal cavity bones. The bony recesses that contain and protect the eyes, this complex includes zygomatic, sphenoidal, frontal, palatine, ethmoid maxilla. The lacrimal fossa, is a shallow depression that marks the lacrimal gland, where you have basically tears coming out. That lubricates the eye surface. You always have to have that lubricated. Supraorbital margin. This is a thickened front bone area. Protects the eye. You have the supraorbital notch. This provides the passage for blood vessels for the eyebrows, eyelids, and frontal sinuses. The lacrimal sulcus is a groove, okay? It marks the site of the lacrimal sac that leads to the nasolacrimal canal. So what's the nasolacrimal canal, you ask? It's formed by the maxilla and the lacrimal bone and houses the nasolacrimal sac, which carries tears away from the eye. The infraorbital foramen, this marks path of the seventh sensory nerve. By the way, as a hint, you may want to hot page this, and what I mean by hot paging is maybe put a little tab or something, but when you do the eye sensory system, you can come back to see these bones again, and this will probably make a little bit more sense. Then we also have, excuse me, the zygomatic facial foramen, which sounds like a mouthful. It carries sensory nerve that innervates the cheek. Here we are, infraorbital foramen. Okay, the zygomatico-facial foramen right here. The lacrimal fossa, the supraorbital margin, the supraorbital notch. This notch may be completely closed in bone, so it'll become more of a foramen as opposed to just merely a notch. You have the nasolacrimal canal on this side and the lacrimal sulcus. Okay. When we talk about the nasal complex, this includes bones that enclose the nasal cavities and the paranasal sinuses. These are air-filled chambers that connect to the nasal cavities. So these include the maxilla, the vomer, the ethmoid, the nasal bones, lacrimal bone, sphenoid, frontal bone, palatine bone, and the inferior nasal conchae. You got to keep in mind that, again, I said to you before, the air cells, the sinuses, and all this, extremely important. If anybody's ever had a sinus headache, I'm sure you probably understand that. But the ethmoid air cells form a network that secures mucus to flush the nasal cavity surfaces. The maxillary sinuses are the largest sinuses. They produce mucus to flush clean, again, the inferior surfaces of the nasal cavities. The frontal sinuses develop after the age of 6, and some people don't even have them. We've already talked about the superior and inferior nasal conchae, and the sphenoid sinuses are found in either side of the body of the sphenoid bone. I've mentioned already the perpendicular plate and horizontal plate, and the functions of the paranasal sinus. As I mentioned before, lighten the skull's mass, allow voice to resonate, as well as provide extensive area for mucous epithelium. I'm sorry if there's a typo there. Inflammation due to these infections in the sinuses via bacteria, fungi, or virus is called sinitis. And probably for those who have suffered sinitis, you hear the doctor saying, no, I'm not going to give you antibiotics. This looks like it's more viral. The reason in part is a lot of patients had been using it for the sinus problems, and it wasn't helping, but it was providing bacteria with the opportunity to develop antibiotic resistance. So there's a lot of hesitancy in giving this for sinusitis situations. And here you have it. The ethmoid sinuses, the ethmoid air cells. You can see the maxillary sinuses here and here. And then, of course, you've got the nasal cavities here and here. You've got also the separation by the vomer, as well as the perpendicular plate of the ethmoid. Moving on. We have talked about this, and I think I've had a repetition on the slide. Sorry about that. Here we go, moving forward. You see here in the frontal bone, there are some frontal sinuses. The ethmoid has both the superior and middle nasal conchae, and of course you have also the inferior nasal conchae, which is down here in the blue. And you can see the hard palate here. Notice that you're going to have the horizontal plate right here, excuse me, and the pterygoid plates right down here. That's what those funny names were earlier. Okay, so you have a pair of sphenoidal sinuses located right here. And we're going to move on. Let's talk about the mandible bone. It's subdivided into a horizontal body and an ascending rami of the mandible. Forms the lower jaw. Articulates with the mandibular fossae of the temporal bones. Bone markings include teeth, which fit into sockets of the bone. This is called a gymphosis joint. Condylar process, which articulates with the temporal bone at the temporal mandibular joint, TMJ. The mandibular notch is a depression that separates the condylar and the coronoid processes. The coronoid process is an insertion point for the temporalis muscle, which helps close the jaws. The ramus is the ascending part. It starts at the mandibular angle. The masseter muscle, big muscle, attaches to the lateral surface. We have also the mandible body, which is really a horizontal part, the alveolar part, which is the site that supports the teeth, the mental foramen, which is the opening for the sensory nerves from lips and chin. The medial surface, basically you have the myohyoid line, which is the insertion point for the mylohyoid muscle that supports the floor of the mouth. The mandibular foramen is the entrance for the mandibular canal, the passageway for blood vessels and nerves. This is what basically dentists use to anesthetize in this area to work on the lower jaw. And you can see this over here. The mental foramen here, the alveolar part right here, which is part of the jaw. Of course, you've got the teeth here. You have the mandibular angle, and you're moving upward. You have a mandibular notch here, which separates out the coronoid process, which is right here, from the condylar process, which is right over here. Here's the condylar process. Here's the head of that. That's going to be the TMJ. The coronoid process is over here. You have the mylohyoid. This is on the inside of the jaw. You have also the mandibular foramen right here. Okay? So, what do? We move out of the skull completely. I know you're just rapidly excited about that. Yeah, no, I know, I'm sure. Yeah. Anyways, we're going to move on. We're going to get into the hyoid. And the reason I get into this, because sometimes it's ignored. And it is important. It supports the larynx and is the attachment site for the muscles of the larynx, pharynx, and tongue. It is consisting of several structures. One of them is referred to as the greater horn, greater cornu. Supports the larynx and is attached to the muscles that move the tongue. The lesser horn, the lesser cornu, is attached to the ligaments which suspend the hyoid and the larynx beneath the skull. In the auditory ossicles, you have one set on each side of the head, okay? And this is located in the middle ear. You receive vibrations from the tympanic membrane. So we have sound waves coming in, they bounce off the tympanic membrane because of vibrations. This vibrations, you have the first of the bones attached to the membrane, they start vibrating, they pass these vibrations over to the next bone, which is the incus, and the next bone, which is the stapes, which is attached to the inner ear structure called the cochlea. What you have is a process called transduction. You're converting sound from sound waves to neural impulses. So you can see here, we go back to the hyoid. Here's the body of it, the lesser horn, the greater horn. And you notice that it is not attached to any bones, but the problem is that it's hard to sometimes show this to students in a skeleton because a lot of times they don't include this or it's been, abused, and so it's missing. The malleus, incus, and stapes, the hammer, anvil, and stirrup, these are all found tiny little bones, and you've seen them in the lab. They're tiny, extremely small. Now, at birth, our cranial bones are connected by fibrous connective tissue that allows passage through the birth canal without damage to the brain. And this is where we're going to get into fontanelles. These are large fibrous areas between the cranial bones. Anterior fontanelles are the largest. They lie between the frontal, sagittal, and coronal sutures in the anterior part of the skull. The posterior fontanelles, they're located between the sagittal suture and the lambdoid suture in the posterior part of the skull. You have two others. The sphenoid fontanelle lies on each side of the skull at the junction between the squamous suture and the coronal suture. The mastoid fontanelles lie at the connection between the squamous and the lambdoid suture. You can see this development, and you've also seen this skull in the lab. If you have time, take advantage of reviewing this, okay? What you see here is from a 3-month fetus to a newborn. This allows some flexing without any damage to the brain. This will eventually calcify, and you will see this as you have growth and maturation here. So basically you have the anterior fontanelle here. You have basically the posterior fontanelle over here. Okay? And you can see this here, the anterior fontanelle, and you have the posterior one. And then if you look on a lateral side here, what you have is the sphenoidal fontanelle here, the mastoidal, nearby the mastoid bone, right there. Okay? That hopefully will help. Now we're going to move through the vertebral column. It consists of 26 bones, 24 vertebrae, and 2 sacrum, and 2 that basically are the sacrum and the coccyx. Each are labeled by number and a first letter. So the vertebral regions are C1, C2, C3, C4 for cervical. T1, T2, T3, T4 for the thoracic. Lumbar is L1, L2, L3, L4, L5, because that's as many as you have for lumbar. Then S for sacral. Coccygeal, to avoid confusion with cervical, they usually put a C and then a small letter O. Okay. Now there are several spinal curves. You have to be clear about them, and they are the cervical, which is the secondary, develops as a child learns to balance weight on the head of the cervical vertebrae. The thoracic, which is primary, and that accommodates thoracic organs. The lumbar, which is secondary, and it balances the weight of the trunk over the lower limbs. And then the sacral, which is also considered primary, accommodates the abdominal pelvic organs. So you have several that allow for important areas such as thoracic and abdominal pelvic organs. And then you have these other ones that are involved with weight distribution and maturation. Here are the curves: the cervical, the thoracic, the lumbar, and the sacral. Here are the bones, as you can see, C1 through C7. We're going to go through them in a minute. T1 to T12, L1 to L5, and then we have sacral, which is a fused bone, and the coccygeal. Now, I do encourage you to do this. There are regional comparisons of the vertebral structures of the cervical, thoracic, and lumbar. You can see this chart. Excuse me. The best way to do it is go into the lab and identify a cervical, a thoracic, and a lumbar. Not merely just the vertebral foramen, not just the vertebral body, because those will be relatively easy, but also take a look at the spinous process and if there is a transverse process. Most of the transverse process are pathways for blood vessels, and you're going to see them mostly in the cervical. Keep in mind that as you go from cervical to thoracic to lumbar, that body is going to get wider and wider. Why? Because you're now carrying more and more of the body's weight. When we talk about the parts of the vertebrae, first off, we have the articular process, which extends superior and inferiorly. It articulates with the adjacent vertebrae. The vertebral arch forms the posterior and lateral margin of the vertebral foramen. The vertebral body is also part that transfers the weight to the axis of the vertebral column. When we talk about the lateral section, we have the intervertebral discs. These are interconnected by ligaments, but separated by pads of fibrocartilage. So basically, if you tried to stack them all together, those separated bones. Here's the question: What am I doing wrong, Doc? Why aren't they all stacking together? Because in between them are these intravertebral discs, and aside of them, there are these stabilizing ligaments that help keep them in this sort of somewhat straight line or semi-straight line pathway. And then you have the intervertebral foramina, excuse me, which is the space here where you're going to have nerves and blood vessels pass through. So here are our articular processes. Here is our vertebral arch, and here is our vertebral body. When you talk about the vertebral foramen, there it is. When you talk about the arch, there are several components that you need to know. First, the pedicles. Next, the transverse processes. Then the lamina, and finally the spinous process. You're going to note that the spinous process differs in size, direction which it's pointing, either straight out or inferiorly, and it gets either just a bare strip, or it's more of a point, or it's more like a fan. And this is because you have to keep in mind that these aren't just randomly there. They're attachment sites for muscles, etc. Excuse me. In the vertebral canal, we have combined the vertebral foramen, which encloses the spinal cord. The vertebral arch, as I mentioned to you, you have the spinous processes, which projects posteriorly from the vertebral laminae to fuse to make the vertebral arch. The lamina forms the roof of the vertebral foramina. The transverse process projects laterally on both sides. The attachment, it is basically the attachment site for muscles and also for ribs. The pedicles form walls of the vertebral arch and connects the arch to the vertebral body. Sounds like a lot, can be confusing. Don't panic. Take it step by step. You also have something called the articular faucet. The articular process has a smooth concave surface. So basically, how do you keep them all nicely aligned and yet flexible to a degree? You have the superior and inferior articular processes. The superior articulates with the inferior process of the superior vertebrae. That's confusing. And the inferior, articulates with the superior process of the inferior vertebrae. What? Here's what I'm looking at. Here you have these extensions. This is the superior. These are the inferior. How do you have these vertebrae connect one to another? If you look at what this is the inferior articular process. It connects to the next one down, which happens to be its superior one. These are all synovial joints, which we're going to get into next week. This is how, in part, you have alignment of the vertebrae. You're going to have, if you see this centerpiece here, yeah, okay, that's the spinous process, but muscles are going to be attaching here and here and here. But how do you keep these things aligned with each other? By these structures right here. Let's talk about the cervical vertebrae. I'm going to move through this relatively quickly. The two biggest ones that you really need to know are the atlas and the axis. But I do encourage you to also take time to review the C7, which is the vertebral prominence. Okay? Cervical vertebrae, there's 7 of them. The smallest bones in the vertebral column. The transverse foramen is a passage for blood vessels. You really only see that with cervical. The 3rd through the 6th vertebrae have a spinous that is short and bifurcated, meaning forked. C7, the vertebral prominence, are distinctive, long, and prominent spinous process. They don't bifurcate. And it's palatable if you go from the skin surface. You just basically go back there and tap yourself in the back. Oh, yeah, I can find that. The ligament nuchae attaches to C7 and extends to its insertion along the external occipital crest, going all the way back to the occipital. The occipital bone. What's the function? To support the skull, enabling the head movements back and forth and from side to side, as well as protecting the spinal cord. C1, atlas. Ring-like short. Basically, it has an anterior arch and a long posterior arch. It's basically the bone in which the world, like Atlas, sits on. In this case, it's the skull. The inferior articular faucets articulate, that is, come in contact with the occipital condyles. This is where you form the atlanto-occipital joint. It allows you to make the yes movement, up and down. Now there's a transverse ligament on C1. It holds the dens, otherwise known as the odontal process of the axis. The axis has a peg-like structure, dens. It sits upward and extends superior from the body. It forms the atlanto-axial joint. It allows you to basically do this. No. Shake your head back and forth. Allows for a rotational movement of the head. Here you see this. Here's the transverse ligament. This is C1. This is C2. Atlas, axis. Notice on the side here you have these transverse foramen. This is where blood vessels are coming down, okay? Notice that the spinous process is forked, bifid, okay? And notice that the vertebral body is relatively small, okay? Now, you see where the articular faucets are? From here, you literally have the skull sitting on top of C1. Let's talk briefly about the thoracic vertebrae for a few minutes. The thoracic vertebrae, there's 12 of them. They have articulations with 12 pairs of ribs. The thoracic vertebrae typically are wider, stronger because they're now carrying more weight. So they're somewhat heart-shaped in the body, and the foramen is circular. You have a spinous process that projects inferior, so downward, okay? And the costal faucets, you have a superior and inferior. They are articulation sites for the synovial joints with the ribs. So here's our spinous process. Notice that it goes downward. Here we have a vertebral body that's somewhat like a heart-shaped. You have a round vertebral foramen. You have superior articular faucets. You are going to have also, basically, you're going to have this inferior costal faucet here, a superior one here. This is for the attachment of the ribs. Notice you have the 12 bones, each marked, T1 through T12, okay? The lumbar vertebrae are located in the lower back between the thorax and the pelvis. The largest individual vertebrae, and they support the greatest amount of the body weight. They also provide a secondary curvature, which is a special adaptation for bipedal locomotion. Basically, another way of saying is, so you walk on two legs. The vertebrae body is large, and it may be either oval or kidney-shaped. The spinous process is short, it's paddle-shaped and projects posteriorly, okay? The transverse process is long and slender. What are we talking about? Here's the spinous process. It's a big, wide thing. Somewhat slightly down, but you can't miss it. It's much different from thoracic. And you notice how you have this somewhat different secondary curvature here. Here's L1, 2, 3, 4, 5. Notice you have the sacrum right here. Look at that big, heavy vertebral body. Yes, folks, that's in you too. The reason is you have a lot more weight on this particular area, so it has to be strong. You see the pedicle, the superior articular process, the inferior articular process. They are all interconnected here. And of course, you've got the transverse process here and here, okay? Now we get into the sacrum and coccyx. The sacrum develops as 5 separate vertebrae. They start 5, but by somewhere between the ages of 16, 18 starting, but definitely ending by the age of 20, they're all fused together. When we look at the anterior part, we have the transverse lines, there's 4 of them, areas of fusion between the original sacral vertebrae. You have the sacral promontory, which is the anterior margin of the superior surface, the base. It's an important landmark for obstetric pelvic measurements. The apex is an inferior end of the sacrum. The sacral foramina are openings through which the sacral nerves pass to reach peripheral structures. The ala is the wing on each side of the base to provide the attachment for the muscles. When we look at the posterior part, we have the superior articular process. This is the sacrum site that articulates with L5 lumbar vertebrae. The medial sacral crest is the central bony ridge. It's formed by the fusion of spinous processes. Okay? So the spinous processes have not gone away, they just fuse together. You have the sacral hiatus, which is the opening at the inferior end of the sacral canal. Opening for what? Nerves. Sacral tuberosity, rough area posterior to the articular surface. The attachment site for ligaments that stabilize the sacroiliac joint. Remember, you're going to have the attachment down here for the coaxial bones, basically the ilia and etc. This is where you're going to have the pelvic girdle connect. The auricular surface articulates with the pelvic girdle to form the sacroiliac joint. The lateral sacral crests mark fusion of transverse processes. The lateral sacral crests are enlarged, thickened to transmit the weight of the upper body to the ilium and lower limbs. You have also a sacral canal, which is a continuation of the vertebral canal. Now we move to the coccyx. Everybody minimizes the importance of the tailbone. These are 3 to 5 coccyx vertebrae. They're very small. They fuse together by age 26. The coxal geocoruna are rudimentary superior pair of articular processes of the coccygeal vertebrae. They project upward and articulate with the cornu, of the sacrum, and on either side complete the foramen for the transmission of the posterior division of the 5th sacral nerves. What we're basically saying here is these have basically allowed the sacral nerves to come out. Now, there is a model in 317 if you want. You can see it. Basically, it peels away some of the sacral so you can see some of the nerves coming out there. The coccyx is also the site for attachment of tendons, ligaments, and muscles. The insertion point, for example, for some of the muscles of the pelvic floor. Here's the coccyx. Here's the coccygeal cornu. Here is the sacral cornu, the sacral hiatus, the lateral sacral crest, the auricular surface, the sacral tuberosities, you hear, the sacral canal, the superior auricular process. This is basically attachments here for L5. You can see this also as the sacral promontory here. The ala here are the wings. The sacral foramen, sites where nerves will come out, and the medial sacral crest right here, okay? Now we move back to the thoracic cage because that serves as an attachment for muscles involved with breathing, maintaining the position of the vertebral column, and moving the pectoral girdles and upper limbs. Sorry about the typo. First off, let's deal with the sternum. That consists of the manubrium, which is the broad superior ligament. It consists of a jugular notch, otherwise known as the suprasternal notch, at the superior margin. The clavicles will attach to the manubrium. The body, which is an elongated middle portion, articulates with the 2nd to 7th pair of ribs. The xiphoid process is the smallest part. It's a cartilaginous well into adulthood. This is the part that you have to be careful of if you try to do chest compressions, okay? And they teach you that because here's the problem. If you press down, you break off the xiphoid process, you now have a risk of literally lacerating the liver. The same thing if you do the Heimlich maneuver. They teach you to do it, look where the belly button is and move up, or I should say the navel. But anyways, when you do this and you pull upward to try to get someone to pop out the blockage, you have to be careful not to damage the xiphoid process again. Now, all 3 fuse together during adulthood. There are 2 joints that are really important. Excuse me, a joint that is very important is the sternal angle. That's between the manubrium and the body. The 2nd pair of ribs attach at that site. The costal cartilage is also extremely important here because they connect the ribs to the sternum, either individually or in groups. Continuing with earlier, We're going to talk about the thoracic cage. We're talking about the ribs now. Ribs 1 through 7 are referred to as vertebral sternal ribs, true ribs. They have costal cartilages that directly are attached to the sternum. So rib, costal cartilage, sternum. 8 through 10 are vertebrochondral ribs. Costal cartilages are connected into one another, sort of fused together, and then attached to the sternum via a costal cartilage of rib 7. Okay? Ribs 11 and 12, they're floating ribs. There's no connection to the sternum at all. But ribs play some very important roles, including protecting the vital organs of heart, lungs, thymus, and kidneys. Particularly 11 and 12 play a role in the protection of the kidneys. Ribs articulate with two vertebrae, superior of one, inferior of the other, and the intervertebral disc. Example is rib 5. It attaches to T5, T4, as well as the intervertebral disc between them. Now, this is in effect from 1 through 7. 8 through 12 only have one rib articulation on the superior costal side of each of the vertebrae. The intercostal space is important. What I mean by intercostal is basically the space between the ribs. These are spaces which are occupied by what is referred to as the intercostal muscles. These are essential for respiration. Okay. And here we have the situation. Here's the manubrium of the sternum. Okay, here's the body. The xiphoid process. Now, all of this dark is costal cartilage. 1 through 7 have direct attachment to the sternum. 8, 9, 10 seem to have this costal attachment, which eventually merges together with the rib 7's attachment to the sternum. 11, 12, forget it, they're not even attached. So 1 through 7 is referred to as true ribs. 8 through 10 are referred to as false ribs, some cases. It depends on the terminology. But it's better and more accurate to use the vertebral chondral rib, chondral being the cartilage chondra. And then the floating ribs are 11 and 12. Rib anatomy. The vertebral end, the head articulates with the body of the numerically corresponding thoracic vertebrae, the intervertebral disc, and the body of the superior vertebrae. At the tubercle, which articulates to the transverse process of the numerically corresponding thoracic vertebrae. The neck, which is the short length of bone between the neck and, and the head and the tubercle. There was a typo there. The sternal end, this is the end that attaches to the sternum, consists of a shaft, a body, main part of the rib. The angle of the rib is the site of the rib shaft curvature. Now, it curves somewhat anteriorly and inferiorly toward the sternum. The costal groove runs along the inferior border of the shaft and the pathways for arteries, veins, and nerves. You can see this here. Okay, so you have the head, the neck, the tubercle. You have the angle here, and you have the costal groove right here. Then you can see the attachment here to the vertebrae. The tubercular faucet of the rib articulates, comes in contact with the transverse costal faucet of the inferior vertebrae. Okay? And here you have basically the head having contact with the superior articular faucet. This is going to conclude part 1. I will then go into part 2 with the appendicular shortly.